I will be actually discussing about some case scenarios which usually come in your CBS exam, and in the recent past two exams there are some rare questions that is being asked from various domains. So I will be actually giving you a scenario so that you will be exactly knowing how the pattern of the exam would be. Okay? So we will go a little bit fast. So you should remember that the questions could be lengthy. Okay, we can't complain that yes, the question is lengthy, so I'm not able to answer it. No, there will be certain hints that will be shown in the questions. You need to pick up those hints and then come to the diagnosis. So that's very, very important. Now, coming to the first one. So here we have a 34-year healthy man who is being admitted to the ICU with refractory shock, progressive hypoxemia, worsening encephalopathy. 2 weeks earlier, he had some self-limiting febrile illness like a sore throat and cervical lymphadenopathy, but he was okay after that. But now he came to the ICU requiring mechanical ventilation, high dose noradrenaline, and his examination reveals jaundice, hepatosplenomegaly, diffuse petechiae, and generalized edema. Now, coming to the labs. So, when you see the labs, just see how to read those labs. So, here the patient has anemia, thrombocytopenia, neutropenia. His inflammatory markers are very high, like ferritin is high, triglycerides are high, his fibrinogen is less, liver enzymes are deranged, he has AKI, and he has deranged coagulation profile with hyperlactatemia. So, this is your questions that they have given. And the CT just had shown some ground glass opacities with some small pleural effusion. Echo was showing some moderate global LV dysfunction. And they have done additionally some viral tests which had showed his EBV PCR is strongly positive. Now, seeing to the questions. Okay, so here patient has pancytopenia with inflammatory markers on the higher side, and he has a viral infection that has triggered all these things. Okay, so this is one of their favorite questions. So what is the most likely diagnosis? Okay, these are the questions that they've usually asked. So using the HLH criteria, identify which diagnostic criteria are filled, discuss the limitations of bone marrow hemophagocytosis in diagnosing HLH in critically ill patients, and outline a comprehensive ICU management strategy for this patient. So you have to basically pick up the hints that's been given in the question. So we all know this is a HLH case. So you should know what are the diagnostic criteria for HLH. How do you manage the patient of HLH? And certain other things. Okay. So also, if you go to the question here, they've asked about HLH 2004 criteria. So this is a old criteria. So you should also know the recent update of the diagnostic criteria. Okay, so the recent update was given in 2014. That is your H score. Okay, so your H score has it is a weight-based scoring system which is based on the clinical, laboratory, and cytological findings. And the scoring is the maximum score that is been given is around 250. Okay. So this is about the first question, their most common question. Now coming to the second question. Okay. Here a 72-year male came with altered sensorium, septic shock. He had a 3-day history of fever, headache, vomiting, progressive confusion. Coming to his past history, he is an immunocompromised trait. How? He has diabetes. He has a chronic steroid use for COPD. And recently the family reported that he had a consumption of unpasteurized cheese. Now, if you see the examination, his GCS is around 11. He is febrile, tachycardic, hypotensive, tachypneic, and he is requiring some amount of oxygen. When you examine him, his neck stiffness was present and he has a positive Kernig sign. Okay, coming to the investigations. So what are the, just see to the positive investigations. Yes, his WBC counts, he has leukocytosis, his CRP is elevated, he has mild AKA, and he has increased lactate levels. Now what you have to concentrate is your CSF analysis. Now coming to the CSF analysis, his opening pressure is high, WBCs are on the higher side, he has a mixed picture. He has 75% neutrophils and 25% of lymphocytes. And he has glucose levels are very low and his gram stain has shown some gram-positive bacilli. Can anyone tell me what is the diagnosis of this scenario? Immunocompromised patient with the CSF analysis. So yes, it is listeria. Okay. So in listeria, there could be either lymphocyte predominance or a mixed picture that is most commonly seen. And you should think that there is a immunocompromised state. And here the hint that they have given is recent consumption of unpasteurized cheese. Okay, so you have a lot of differentials here. Basically, it could be bacterial, it could be viral. Okay, but you should pick up that hint which they give it in the question. Okay, so the questions that they've asked is what is the empirical treatment that you start in these patients? Okay, and why cephalosporins are inadequate in treating listeria? Okay, because listeria is intrinsically resistant to your cephalosporins because of the altered penicillin binding proteins that is present in the listeria. Okay, now this is one of the most important questions that they have asked in the recent exam. So we have a 24-year woman who has been brought with fever, vomiting, dizziness, and confusion for 1 day. Okay, and when you examine, there was some red rash over the trunk and lips, and she has been menstruating, and there is a prolonged use of a high absorbency tampon for nearly 12 hours. This is the hint that they have given here. Okay, so she has high grade fever, she's tachycardic, hypotensive, okay, and she's mildly tachypneic. Now, when you see the physical examination, you have a diffuse erythematous rash that is present. Okay, she has some altered mental status and extremities are very cold. Coming to the investigations, leukocytosis, thrombocytopenia, AKI, elevated liver enzymes, and lactates are on the higher side. And within 48 hours, the rash spread so badly that there was a desquamation that has been occurred. So, can anyone tell me what is the most likely diagnosis in this case? Very good. Toxic shock syndrome. Very nice. So here you have that tampons that has been given as a hint. Okay, so the likely questions that will be asked here would be what organisms are responsible for that? What is the pathophysiology of development of this toxic shock syndrome? And what is your ICU management? And why is clindamycin important in this situation? Because clindamycin is important because when you go to the pathophysiology here, it is a toxin mediated cytokine release that is happening in TENS. So that is the reason for the toxin suppression. The antibiotics other than which act on your staphylococcus and streptococcus, you should add clinda for toxin suppression. Okay. Now coming to the next question. So if you see the question here, it is a 42-year diffuse large B-cell lymphoma who is being admitted after receiving your CAR T cell therapy. So initially, if you see a patient with diffuse cell or any other lymphoma or anything, post chemotherapy, they would give you neutropenic sepsis scenario. But now that has been uh, uh, now that is become a very basic questions. Now it is a hi-fi question. Now they have gone into the CAR T cell therapy. Now post the therapy, 48 hours later, she had developed progressive hypotension and confusion. So she was febrile, she was tachycardic, severe hypotension. She was requiring 6 liters of oxygen. Now coming to the neurological examination. Here the patient is agitated and disoriented, unable to name objects. GCS was 13, but there were no focal neurological deficits. Now, because it is a CAR T cell therapy, the complication is the thing that they are asking here. So here the CRP is elevated, ferritin on the higher side, liver enzymes elevated, creatinine is increasing. Okay, blood cultures are pending and CT brain is normal. Can anyone tell me what is the diagnosis here? Immune related adverse effects. Okay. So it has a specific name. So what is that name? It is cytokine release syndrome. But if you see the question, there is not only a cytokine release syndrome that is happening, but it is affecting your neurological system. And that is known as ICANS. That is immune effector cell associated neurotoxicity syndrome. Okay, so the range of questions might actually go to this higher level also. Okay, so that is very, very important. So it's not those simple questions that is being asked in your exam. So this is a very high-end question. So what was the questions that has been commonly asked? So what is the likely diagnosis? What features will support your cytokine release syndrome? What is the different gradings that you can see in the CRS? And what is your management? Okay, so here, what are the features that support your cytokine release syndrome? One is the recent CAR T cell therapy. Patient has high fever. There is a vasodilatory shock, hypoxia, organ dysfunction, and there is elevated inflammatory markers. Okay, so all this support your CRS since it is affecting the neurological system predominantly. So there is an association for ICANS also. Okay. So a lot of grading systems are there. I think we will not go in detail about that. And you should know what is the specific therapy for CRS. Okay. It is tocilizumab. And in refractory neurotoxicity, even steroids are helpful. Now coming to the next question. So this is about whatever I was dealing was about your hematological system. Okay. And your infectious diseases and sepsis. Okay, so these two things I've just completed. So other things that they might ask is about the different types of meningitis. Okay, especially HIV related meningitis like your cryptococcal or toxoplasmosis. So those are also most commonly stressed topic in Edic. Okay, next, the recent sepsis guidelines can also be included here. So please go through the recent sepsis 2026 guidelines. Now, next coming to your uh, burns. So burns is also one of the most important topic. So 42-year male is admitted to the ICU who is been rescued from an enclosed space industrial fire. Okay, this is one of the hint. Okay, so total body surface area that has been involved is 18%. So most of it was face, neck, and upper chest. So he was tachycardic on examination, mild hypotension, tachypneic. He was hypothermic, and he is requiring around 100% of FiO2. On examination, there was facial burns with perioral edema, cinched nasal hairs, some carbonaceous sputum, and there was mild inspiratory stridor. And when you see the ABG, okay, there is hypoxemia with type 2 respiratory failure. And when you, important thing is, your lactates are very high and his carboxy hemoglobin level is 14%. Okay. Now the patient becomes progressively confused during assessment. So what would be your next best step in management? It is intubating the patient. Now you should know they can ask either about carbon monoxide poisoning or cyanide poisoning. So you should know the normal levels of it. Okay. And what are the different manifestations with each of it. Okay. If they tell it as a cherry red skin discoloration, okay, then you should think of cyanide poisoning. Okay, so here they have directly given you the carboxy hemoglobin levels. Sometimes they might not mention even the levels and you need to just think of either cyanide or carbon monoxide poisoning. Now, what is the management of carbon monoxide poisoning? An important thing is you should know in detail about the hyperbaric oxygen therapy. So what are the indications? So at least how is it given? How much percentage? And how will the patient recover? This is very important. Okay, so what is the half-life of your carboxy hemoglobin? So this also they might ask as a question. So when you give a hyperbaric oxygen therapy, what is the half-life of carbon monoxide? That is there. So you should remember that it is 20 to 30 minutes. And you should know what are the indications of hyperbaric oxygen, especially in case of carbon monoxide poisoning. Next. Next comes one of your hematology topic again. So this is also one of their favorite questions and a recurrently asked question, but you need to identify the answer, then only you'll be able to go for the further questions. So here a patient admitted with severe community acquired pneumonia, has a history of hypertension and ischemic heart disease. So for the pneumonia, they've started IV antibiotics. Patient is shocked, so vasopressus, and they've started with unfractionated heparin for DVT prophylaxis. His platelet count on admission was around 2,40,000. On day 6, when you repeat the platelets, it is around 92,000. And when you see, the patient develops swelling and pain of the right leg. And when you do an ultrasound, there is a proximal DVT. So his INR is 1.1. His APTT is mildly prolonged. Fibrinogen is normal. And there is no cystiocytes on blood film. So what is the abnormality that is being shown here? Is your platelet drop on day 6. Okay, so this will be your HIT, heparin-induced thrombocytopenia. So you should know what are the features that support the diagnosis. You should know the underlying pathophysiology behind that. And you should know your HIT score, the 4T score. Okay, and what investigations you would request. So the most two important investigations are your immunological assays for your PF4 antibodies and your serological assays, and how do you manage this patient. So these are the common questions that is being asked in your HIT scenario. Okay. So this one is a very easy question which I don't want to discuss much. Okay, we will go for this. So a 54-year-old man is admitted with, again, community acquired pneumonia. Okay, on day 3, the nurse notices some mild oozing from the central venous catheter site. So background, there is no previous bleeding history. There is no other any coagulopathies in the family. So he was just receiving some prophylactic unfractionated heparin flushes through arterial and the central lines. On examination, he was hemodynamically stable. But when you come to the results, almost most of it are normal, except your APTT, which is markedly prolonged. It is around 92 seconds, and your D dimers are mildly elevated. So this is a case of isolated elevation of APTT. So you should know how to evaluate if a patient of isolated elevation of APTT comes to you. Okay. So whenever a patient with isolated APTT comes to you, the next step is the thing that you should do a mixing study. So what is mixing study? Here you are going to just mix your patient plasma with the normal plasma. And if your APTT gets corrected, then it indicates that the patient has some factor deficiencies. Suppose even after the mixing studies, if your APTT doesn't correct, it indicates that there is some inhibitors, and the most common one is your lupus anticoagulant. Okay, so taking this flow chart, you can actually create some 5 to 10 questions. Okay, so this flow chart is very, very important, and this is one of their favorite question of isolated elevation of APTT. Okay, I'm just going to show some. Okay, so this is one. So as Sir told, CTs should be practiced very clearly. So your CTs are not so simple as being shown, like emphysematous pyelonephritis or just pancreatitis. Okay, a lot of CT angios has also been discussed in the recent exams. So this is one of the example for the same. Here, the 72-year-old man came to the emergency department with severe abdominal pain, which is out of proportion to the physical findings. Coming to the history, this is a hint here. He has a chronic AF who is not anticoagulated with other comorbidities. Okay, patient is presently in AF, heart rate is 128, he is hypotensive. And when you see the abdominal examination, he has just mild tenderness with minimal guarding. Okay, and you have hyperlactatemia and metabolic acidosis. So when you see your CT angio, there is something that is happening here. So can anyone tell me what is the CT? Yes, it is mesenteric ischemia. Okay. So what's happening is there is a thrombus that is sitting in the superior part of the mesenteric artery. So there is no further flow that is been that is seen further. So this is a mesenteric thrombosis that is happening. So please be perfect with your CT angios, especially of the brain and the abdomen. Okay. So this is a trauma case which I don't want to discuss. So you should know, as Sir told, a lot of CRRT complications that are very important for you. Okay, especially your regional citrate anticoagulation. So recently they've asked about citrate toxicity. So how to diagnose citrate toxicity, how to differentiate between citrate overload and citrate toxicity. Okay, so you should be perfect with the CRRT. Each and every complication of CRRT is very, very important. Okay. So due to time constraint, I'm not able to go it in detail. So this is one of the questions that they've asked in the recent exam. So this is not a most common question. So I just wanted you to just go through this. 62-year-old man with poorly controlled diabetes mellitus and CKD. He's admitted to ICU with hospital-acquired pneumonia. So, and they have diagnosed it as MRSA. So he's been started on IV linezolid 600 mg BD. So he had taken it for 3 weeks, post which he developed increased fatigue and generalized weakness, nausea, abdominal discomfort, but there is no hypotension. Mild confusion was there. Vitally, he was actually okay. But when you do the investigations, he had severe metabolic acidosis with hyperlactatemia. Okay. So can anyone tell me what is the most likely diagnosis in this patient? Okay. Yes, it is linezolid induced lactic acidosis, but you should basically mention what type of lactic acidosis it is. It is basically type B lactic acidosis that is happening. So you should know how to differentiate between type A and type B lactic acidosis. What is the mechanism behind this antibiotic causing lactic acidosis, and who are the patient at risk of this, and how do you manage this type of lactic acidosis? So this is one of the recent questions that has been asked, which is not so common also. So you should know about the type B lactic acidosis. Now, they have asked in the trauma, anything can be asked: liver lacerations, spleen lacerations, how do you manage the grading of the spleens? And recently they've asked about your flail chest. Okay, so what is flail chest? You should know. Okay, why is there a paradoxical breathing in the flail chest? You should know. Okay, what is the different analgesia that can be given for flail chest, and how do you manage? And in which cases would you like to operate in these patients? Okay, so that's also a recent questions that is being asked. Okay, and the last one here is your CRRT alarms. Okay, so all the alarms of the CRRT you should know. Okay, at least one question is most expected from these alarms. So they will give you a scenario and they'll show you the screen and they will let you know what is this alarm, why is it happening, and how to troubleshoot these alarms. So that's very, very important. Okay, so these are the different alarms that is most commonly seen in CRRT machine. Okay, so these are the questions that has been recently in the past 1 to 2 years back. The questions that is being asked. So
Thank you very much, Dr. Niharika, for sharing your like the knowledge and expertise also, and also your tips and tricks for the upcoming exam takers. So with this, we come to the last part of our course. Before that, Dr. Jitendra, if you want to share some tips and tricks, maybe two lines from you.
Sure. Thanks, Professor. And I think everybody have told how to approach. I thought I'll just add 2 points without repeating much due to lack of time. So we all know CBS questions are going to be lengthy, and that is where people are finding it difficult to answer those questions. So, and like Sir said, we have been doing this since past. This is our fourth year, so we have been doing it twice a year, and every session we have at least 500 CBS questions. So, I mean, at least 200 CBS questions every session, and two sessions every year. So, nearly more than 500 CBS questions. And CBS questions, it's not that we are doing it only the common ones, even the rare ones. It's when we have been updating ourselves and even framing questions for the latest ones. Like Niharika was telling, I mean, they're already asking about CAR T cell therapy. If you see last two sessions, we already started discussing about CAR T cell therapy, and we have reframed the questions, and we have been discussing in our CBS what are the expected answers for those questions. So we are updating ourselves also, and you will be staying with us after registering for 4 months. In these 4 months, you'll be at least accessing to nearly 500 CBS questions. So we'll try to make all of you experts in answering this question because it is time which is very important in these CBS questions. So by the time you finish your question, you'll be able to answer. So that's what we'll be trying to do when you are with us. Otherwise, most of it is already.
Thank you, Dr. Jitendra.